Hello, colleagues, and welcome to this Clinical Explainer. Today, we're going to definitively map out the NICE NG235 Intrapartum Care Guidelines. Now, I want to be crystal clear right out of the gate. This explainer is designed specifically for you, the MRCOG candidate. This isn't for patients. We are focusing strictly on high-yield, highly testable facts, exact clinical parameters, and the rigid diagnostic criteria you absolutely need to master for both your exams and your daily practice. All right, let's dive right in. Here's our roadmap for today. We'll be moving chronologically through the clinical pathway. First, planning the place of birth, then moving sequentially through the first, second, and third stages of labor. And finally, we'll wrap up with immediate care of the newborn. Starting with Section 1, Planning Place of Birth and Risk Stratification. Now, here's an absolutely crucial distinction NICE makes regarding low-risk women, and examiners love to test this. For low-risk, multiparous women, planning a birth at home or in a midwifery-led unit means fewer interventions, and the outcome for the baby is literally no different than if they were in an obstetric unit. But catch this. For low-risk, nulliparous women, while interventions are still lower outside an obstetric unit, planning a home birth actually carries a small, documented increase in the risk of an adverse outcome for the baby. You've got to be able to articulate this specific difference when counseling patients. It's exactly the kind of nuance that separates a pass from a fail. Looking at the data on maternal BMI at booking, this is a massive game changer for the risk profile. A BMI over 35 dramatically shifts things. We're talking about a significant spike in intrapartum complications, higher rates of unplanned cesarean births, postpartum hemorrhage, and of course that high-stress emergency transfer from a home setting to an obstetric unit. When evaluating patient comorbidities for absolute indications of an obstetric unit delivery, you must commit these specific indicators to memory. 2 infective markers are frequently tested. First, Group B streptococcus, where intrapartum intravenous antibiotics are recommended. Second, being a carrier of hepatitis B or C. And note this, for Hep B or C, the recommendation stands even if the patient has completely normal liver function tests. Why? Because the baby is going to require a pediatric review immediately after birth. Moving on to Section 2, First Stage of Labor, Definitions and Assessment. Getting this right is fundamental to avoiding premature and unnecessary interventions. You have to strictly differentiate the latent phase from the established first stage. The latent first stage involves contractions with some cervical change, up to 4 centimeters of dilatation. The established first stage? That's regular contractions with progressive cervical dilatation from 4 centimeters onwards. Literally everything, management protocols, expected progression, and ward admissions hinges on that exact 4 centimeter threshold. So during that initial face-to-face assessment, clinical precision is everything. You'll review the care plan and do an abdominal palpation for fundal height, lie, presentation, and engagement. But pay very close attention to the fetal heart rate monitoring guidelines. Auscultation must be performed for a minimum of 1 full minute immediately following a contraction. And while you're doing that, you must simultaneously palpate the maternal pulse so you can confidently differentiate between the 2 heartbeats. Oh, and remember, you only offer a vaginal examination if you actually suspect established labor. For ongoing ward management, this schedule needs to be hardwired into your brain. OSC clinical scenarios are built entirely on deviations from this timeline. You document the frequency of contractions every 30 minutes. You record the maternal pulse every hour. And every 4 hours, you record temperature, blood pressure, respiratory rate, and offer a vaginal examination to assess progress. Next up, Section 3, Second Stage of Labor, Progress and Delay. This phase demands intense clinical vigilance. Before you can even think about starting the clock to diagnose delay, you must verify the patient is truly in the active second stage. The passive second stage is when you have full dilatation but no active pushing yet. The active second stage is officially triggered by either the baby becoming visible or the onset of involuntary or active pushing alongside full cervical dilatation. This is an extremely high-yield comparison for written papers regarding delay without an epidural. For a nulliparous woman, you expect birth within 3 hours. Assess progress at the 1-hour mark, and you must refer for a senior review and diagnose delay after 2 hours of active pushing. But for a multiparous woman, everything shifts into fast forward. You expect birth within 2 hours, assess at 30 minutes, and escalate for delay after just 1 hour of active pushing. Conversely, throw an epidural into the mix and watch how the parameters change. For nulliparous women, the delay threshold stays exactly the same at 2 hours of active pushing. But for multiparous women with an epidural, you now assess at 1 hour, and you diagnose delay and refer at 2 hours of active pushing. So they effectively get an additional hour compared to those without regional analgesia. Section 4, third stage of labor management protocols. The baby is safely delivered, and our focus immediately pivots to preventing postpartum hemorrhage. In the exam, you need to be able to distinctly outline the exact procedural differences between active and physiological management without missing a beat. Active management mandates routine uterotonic drugs, double cord clamping and cutting, and controlled cord traction after signs of placental separation. On the flip side, physiological management involves absolutely no routine uterotonics, no clamping of the cord until pulsation has completely stopped or the placenta is out, and spontaneous placental delivery by maternal effort alone. Finally, Section 5, Care of the Newborn, Immediate Assessment. These are the critical, high-stakes minutes right after birth. First, a very simple but absolute rule. You're recording the APGAR score at exactly 1 minute and 5 minutes for every single birth. No exceptions. Now, if a baby is born in poor condition, say abnormal breathing, heart rate, or tone, you follow this strict pathway. Step 1, initiate neonatal resuscitation. Step 2, make sure you double clamp the cord using 2 clamps. And Step 3, take paired cord blood samples for blood gas analysis. Here is a huge, highly testable point. NICE explicitly states you should not routinely take paired cord blood samples for healthy babies. They are specifically indicated only in this resuscitation pathway following double clamping. Exams love to test your threshold for escalating neonatal care, especially after meconium exposure. So ask yourself, beyond just the presence of meconium, what exact physiological red flags tell you I need a neonatologist right now? You absolutely must memorize these precise clinical cutoffs. You are escalating to a neonatologist if the newborn exhibits respiratory distress, like a rate above 60 breaths per minute or any grunting. Also, if the heart rate drops below 100 or spikes above 160 beats per minute, if capillary refill time exceeds 3 seconds, if body temperature hits 38 degrees Celsius or above, if oxygen saturations are below 95%, or if you see any central cyanosis. These are hard stops that mandate immediate specialist intervention. Wrapping up this explainer, I want to leave you with this final thought. Memorizing these cutoffs for an exam is one thing, but how effectively can you synthesize these rigid diagnostic criteria with the dynamic, unpredictable, and frankly high-pressure environment of the delivery suite? Ultimately, mastering the NG235 guideline isn't just about passing a test. It's about taking these strict, evidence-based parameters and flawlessly applying them to safeguard maternal and fetal outcomes in real life. You know the criteria now, but when the alarms go off at 3 a.m., will you be ready to act on them? Keep studying hard, and I'll catch you in the next explainer.